Good morning. Thank you so much for having us, and what a pleasure to walk through a clinical case discussion with Dr. Tierney. We'll go ahead and get started. A few notes. This case was inspired by a true patient, but a large number of details have been changed to ensure patient privacy. As you heard from Jonathan Chen, Dr. Tierney has been blinded to this case, so he doesn't quite know what's coming. And as a result, he'll be demonstrating true, real clinical decision-making in real time. And then finally, we recognize that we are very fortunate to have a wonderfully diverse group in the audience today, of both clinicians as well as non-clinicians. So we'll aim to define medical terms as we go along so that everyone's on the same page and can enjoy the discussion. Dr. Tierney.
Well, I could start with myself. Prior to this morning, I thought that AI was aortic insufficiency. It ends up being this incredibly complex field that two of my former residents, Tops sitting right up there and Caliph, wherever he is, learned from us. So let the buyer beware.
All right, well, we'll go ahead and begin with the one-liner about this patient. She's a 35-year-old woman who presented to the hospital 7 days after delivering a baby, describing severe left upper abdominal pain and fevers. Dr. Tierney, I'll tell you a little bit more about her symptoms. Very shortly after her delivery...
You want me to just handle that very first line?
I'll provide a few more pieces of information to help get it started, and then please feel free to ask away.
Absolutely.
So her symptoms first began approximately 7 days ago, shortly after her delivery, and they comprise of very severe left upper quadrant abdominal pain. The pain is constant and doesn't particularly radiate. It's been progressively worsening over the last 7 days. At its worst, it's an 8 out of 10 in pain, where 10 is the most unimaginable pain. And it's also been accompanied by what she thinks are fevers, though she hasn't checked her temperature, as well as nausea. So at this stage, Dr. Tierney, I'll turn it over to you. Please feel free to ask anything about the history of present illness, past medical history, social history, family history, or medications. And after we chat for some time, then we'll do a quick summary of everything that you've uncovered before we proceed to the physical exam as well as laboratory data.
Thanks very much. Can we go back just to the very first, the chief complaint? For one thing, you have to know, I work at a VA hospital. So what do you think the chances of me having
So you see this all the time?
seen someone postpartum and a woman at both? So I expect that most of you here will have about as much experience as I do with this, but nonetheless. At age 35, she's common in the modern day about age for childbearing. It's gotten higher over years as women have delightfully entered their own careers, but assume the other difficult challenge of becoming a mother, and good for her. So the issue is really left upper quadrant pain and fever, the two very distinct problems. Those of you who don't know where the left upper quadrant is, you can leave, but ordinarily we in medicine refer to that quarter of the abdomen. And it's important to know that what's there ordinarily. The spleen, for one thing, to which I will return. The left colon, which takes a kind of 90-degree angle at that point. Sometimes problems with the kidney and even things behind the kidney can be felt by the patient in the left upper quadrant pain. You notice it doesn't say necessarily the things we usually ask, and perhaps those of you who aren't physicians have been asked about pain in the past, but will likely get that. What makes it better? What makes it worse? Ever had anything like this before? And a number of almost intuitive questions that the patient themselves has largely thought of and may not believe that it's important to tell you unless you ask. Now, the fact that there's fever raises a great question, and I would like to define it for both physicians and non-physicians here. Everybody says, oh no, fever. Everybody knows that what fever is. Not, I doubt it. Fever is a regulated rise in body temperature. It's not an elevated body temperature. That's hyperthermia. Fever indicates that the normal mechanism that is controlled by the hypothalamus is kind of ratcheted upward. And we'll accept that this is a true fever and not some peculiar abnormality of thermoregulation as the case goes on. Now, you gave me some other points too, didn't you, Tanya?
We started to discuss a little
Yeah.
bit more about the quality of her pain.
Okay.
In that we were hearing that it was constant at its worst, 8 out of 10, had been lasting for the last 7 days and progressively worsening.
I'm going to put in a move to be done with the scale of 10. That dog won't hunt. As they say, where's Caliph? Right? That's what they say in the South. You don't need that. Oh, okay, good. So I want to reiterate that Southern phrase that I picked up back in Emory. That dog won't hunt, referring to 10 out of 10. I realized that was a fool's errand when a patient who had pancreatitis I saw a couple weeks ago told me that his pain yesterday, 10 over 10, was now 12 over 10. So better that it be described in semi-qualitative terms, I think. But the fact that it's constant is important. And specific questions that might not appeal to a patient. The spleen sits under the diaphragm, and the nerves that keep all of you breathing somewhere between 12 and 14 times per minute come through the chest and innervate the muscle in the diaphragm. Those are the third and fourth and fifth cervical nerves. But they also have sensory, they convey sensation, pinprick, and the like in an area around the shoulder and the lower part of the neck. And so sometimes the brain, despite all the advances in it that we've heard about earlier today, doesn't always get it right and thinks that something going on in the spleen, which touches the diaphragm, is felt instead in the shoulder. So we would ask her, because that would be a decisive historical question. If she had shoulder pain with this, then a process confined or dominantly involving the spleen would be high on that list. Other things that touch the diaphragm that are felt in the shoulder include lower lobe pneumonia, pulmonary embolization with infarction of the lower part of the lung, infarction meaning death of tissue, and the like. So either the lower part of the lung or upper part of the abdomen for the shoulder. The constant, we expect regulated rises in body temperature to show some bump in the evening, the lowest normally being about 6 a.m., the body temperature, and everyone here. And you add about a degree of that to the evening. That's why one house officer here, I saw one of ours, that's why you get called on the evening shift for fever, because the body temperature goes up during, say, 8 p.m. to midnight. So we'll keep those things in mind and just move on. So I'm wondering, why would a woman who's postpartum have a problem in the spleen or possibly in the colon? I'd ask her GI symptoms too. And the answer to that question may depend upon a lot of other past historical items. For example, does she have a hemoglobin problem like, say, sickle trait, which could be producing splenic infarction? Let me see here. I don't want to get too exotic. Sickle hemoglobin, of course, is carried by about 8% or so of Africans, and it would be important to know, for example, if she had that, or if she were Mediterranean, could have, for example, a type of hemolytic, meaning destruction of the red blood cells, problem that stems from thalassemia, as it's called. So spleen involvement is interesting. Sometimes the spleen may reflect a problem way remote in the body. I joked about AI here at the beginning, but endocarditis, which commonly affects the aortic valve, frequently produces abscesses in the spleen, which may produce pain like she has. So this is an intriguing scenario so far, even to a non-woman, non-gynecological, non-obstetrical. Well, let me see. What are other ways can I?
Well, perhaps
Anyhow.
I'll begin by answering some of the questions that you started to pose. You initially moved towards thinking anatomically about the left upper quadrant, and that's where the spleen lives. And so you asked about the sometimes associated left shoulder pain. And as it turns out, she has been having some left shoulder ache for the last 7 days as well. She hadn't thought much of it until you brought it up. In regard to your other questions about her background, she's white and she's never been told about a history of sickle cell.
Mm-hmm. It's important to know that sickle hemoglobin is not confined only to Africans. There is a community somewhere in Greece, I think, a small area, in which every person who is phenotypically white is also carries sickle. Hemoglobin is susceptible to the same things that we've come to know. So the terminology probably begs to be changed exactly, but nevertheless, by and large in this country, it's going to mean a person who's African American. And you must know, for a little pearl, sometimes we call pearls glass beads when they're not really up to snuff. A pearl otherwise, for you non-docs, is something that is just a really high, valuable gem, usually of wisdom, but not always. And so I'll give you this one. Anything that disease can do, so can trait. That means anything that SS, hemoglobin, that is the full expression of sickle cell anemia, can cause symptomatically, so can patients who have just carry one of the two genes for it. Anyway, I'm not going to say anything more about hemoglobinopathies, but it's interesting she has something in the shoulder. Remember, the left upper quadrant doesn't necessarily mean the abdomen. We have to respect the left lower lobe of the lung, even the pericardium, for sure.
Now, at this stage, we've been able to see how you navigate the patient's initial concerns. You thought both anatomically, when hearing that the left upper quadrant was involved in the abdomen, but you also thought by different concerns and different issues, navigating both left upper quadrant pain as well as separately navigating fever as you begin to round out the history of her present illness. Is there anything that I can also help answer in way of her past medical history, social, family history, or medications?
Certainly, we have to ask GI-related questions too. Is there any history of chronic abdominal pain? Is she known to have some chronic illness, for example, inflammatory bowel disease that could infect the colon? Was she hypotensive at any time during the delivery, which would result in, say, perhaps colonic ischemia? Mm-hmm. For that matter, possibly splenic. So we don't want to overlook other things. We're certainly going to address whether she has kidney issues too, although that's usually in the flank, not in the left lower quadrant so much. And the duration is important. This is something that's only lasted 7 days. We should not pin that down. Never before the delivery. And if you fail to, let's avoid medical mistakes here if we can, for you non-docs and for the docs too. If you fail to go back and read the op note for the delivery, you have made a mistake. Was there some problem with the delivery. Remember we mentioned she was in her 4th decade, and while it may not be exceptionally higher, I would venture to guess that there might be more difficulty with a delivery at that age. So we need to do the blocking and tackling part. You know, football and basketball, I got my Warriors tie on today. They won last night. So instead of Dr. Vergay's lovely Stanford bow tie, which was in my pocket, I chose the Warriors. So anyway,
Now, in regards,
it's not all the Steph Curry bomb from 30 feet. It's the passing and the nuts and bolts of this. Often medicine is not necessarily that exciting. It's just doing your homework.
well, in regards to some of your questions as part of your homework, she doesn't describe any flank pain. It's predominantly pain that's just isolated to the left upper quadrant. Additionally, you asked about GI symptoms, but she's having normal bowel habits. Her pain doesn't change with taking, or doesn't change with eating food. She's even been taking ibuprofen around the clock, and that really hasn't provided much relief to her symptoms. You also inquired about her delivery. This was an uncomplicated C-section. The reason that the delivery was a C-section was because the child or the baby was in the breech position. For our audience, that's malpositioning, and so it's a less safe vaginal delivery, and as a result, a C-section was pursued. But otherwise, her post-delivery course was uncomplicated, and she did quite well.
No transfusions were noted.
She did not receive any transfusions.
So that's interesting as well. Probably not going to be able to indict that. A breech delivery, in the old days, people might have toughed it out, but I think it's pretty much always going to have a cesarean section these days. I don't have the knowledge of what percentage of all are breech deliveries, but I bet you that phone I left on top of my desk will absolutely have it in there. And I want to make that point. I think it's great that both patients and doctors together can review a symptom or a sign right in real time with their smartphones. And by the way, I would never in a million years, even if I have to stay until midnight writing notes, I would never, ever, ever write a note while talking to a patient. It just sort of abdicates your responsibility as a physician when you look at the screen with like that great cartoon you showed, Tops. It's fabulous.
Any additional questions that I can help answer?
Well,
including?
I hate to ask this because it creates cynicism, indicates that doctors are cynical, and I have not a cynical bone in me. I am blessed to be practicing medicine in every imaginable way. But I think you'd have to ask, does she have any habits that might result in an infection in the spleen? And I specifically refer to use of illegal drugs or parental drugs specifically.
No history of drug use, including no history of IV drug use. In addition, no alcohol use or smoking.
Okay. You can continue. I mean, right now, what I think most clinicians like moi would be thinking, well, what kind of disease is this? And there are only a small number of generic types of illness. One of them is infection, and of course, fever and probably spleen puts that high. Neoplastic, only 7 days. Probably unlikely. It would be super bad luck if that ended up being the case, but we'll respect neoplastic. That's a tumor, folks. Autoimmune has a mean way of showing up in situations like this, particularly if there's associated hypercoagulability, as can be the case in SLE, causing a loss of blood supply and clot into visceral organs such as the spleen. So, yeah, you have to mention lupus in a setting like this, even if totally improbable. Uh, uh, so other types of disorders include metabolic. We have no way of knowing whether she has disturbance of any of the minerals in her blood or any of the other things that we commonly measure and that you get measured whether you need it or not when you go to the doctor. Traumatic, well, there's no trauma, we've been told, though, we don't expect that. Although the spleen is a good organ to take down with blunt trauma and need be respected in the post-motor vehicle patient with shoulder pain if the shoulder exam is negative. Congenital, it's probably not. Again, we tend to have dismissed the hemoglobinopathy, but keep in the back of your mind, degenerative, she's not old enough for that, fortunately. So I'm thinking infectious process, possibly autoimmune process, possibly toxic metabolic, but we'll get to that. I think the first two groups are more likely. It's no different than what any of the rest of you might think.
And as you,
just look at this.
As you begin to talk to her some more, she starts telling you a little bit more about her past medical history. And up until the last few years, she's fortunately been quite healthy. About 2 years ago, she had a cholecystectomy, gallbladder removal, and that was an uncomplicated surgery. And then additionally, in her past medical history, she mentions to you that during her pregnancy, she had 2 deep vein thromboses. For our audience, those are blood clots in the legs. The first occurred 6 months ago, so just on the cusp in between her first and second trimester. And it started with feeling a deep ache in her right leg. So she went to the emergency room where they performed an ultrasound that revealed a right popliteal clot. She was started on a blood thinner, enoxaparin at the time, and just 2 months later, she had the exact same thing happen in the left leg. She felt a deep aching in the leg, went to the emergency room, and an ultrasound revealed another clot, this time on the left leg, showing a popliteal clot. The dose of enoxaparin, the blood thinner, was increased at that stage.
Mm-hmm. This creates or brings up a super commonly discussed entity in medicine and what you're supposed to do about it. And I could ask Califf and Topol or their cardiological days what they think about unprovoked deep venous thrombosis. By unprovoked, I mean she wasn't doing anything by which she came upon this. It just happened in her normal daily activities. So, and also what kind of a workup would she merit for hypercoagulability? The cholecystectomy, which is removal of the gallbladder, I'm sure, maybe some folks in here have enjoyed the pleasure, which is now done by robots, by the way, just to respect the meaning, the purpose of your convention here today. But remember, she had a cholecystectomy at age 32. It's a wee bit young. Does that suggest anything? There are certain phenotypes of individuals who get gallstones, which I'm not going to go into. But one thing always to remember is, could this possibly be a result of a chronic hemolytic state? That's a condition in which the underlying disorder results in a shortened lifespan of red blood cells. And there's a higher incidence of bilirubin stones in the gallbladder, not kidney, but gallbladder, made out of bilirubin. How might one put that together in a super funky way before we even have an exam or anything? Well, you could say that this patient has paroxysmal nocturnal hemoglobinuria. What? What is that? It's another term that tends to put patients at arm's length from their physicians. But don't forget, we are not going to let her go without explaining what that means. Why PNH? Okay, for one thing, it's a chronic hemolytic state, which means that she could have been susceptible to the hemolysis resulting in the cholecystectomy. And 2, it's also for reasons that are unknown, unless there's a hemoglobin hematologist in the room. it's a hypercoagulable state as well. So she could be susceptible to deep venous clots and also to maybe a splenic vein thrombosis as a result of an underlying congenital abnormality. I get a sense it probably isn't, because the presenter doing her job went, that's interesting. Like,
That
what
being
the
said,
hell are you talking about?
That being said, what an incredibly creative way in real time to put together a cholecystectomy for gallstones and a DVT and some sort of possible splenic pathology, if that really is what's causing this left upper quadrant pain.
Well, you know,
Now, there was one.
I'm the only UCSF person on the faculty here. I have to indicate what we, deal with up there. Where's Drew? Where's our man? One resident.
Now, there was a very interesting thing that you asked about. You seem to immediately hinge on the fact that, aside from perhaps the risk factor of forming clots in pregnancy, which is well defined, that it wasn't clear if this was otherwise, these episodes of blood clots in the legs were otherwise provoked.
Yeah, well, that's great.
And actually, as it turns out, over the course of discussion, the patient reveals that before she met you, she was tested for factor V Leiden. And for our audience, that's the most common heritable disorder of hypercoagulability, or the propensity to form blood clots. She was tested for this by prior doctors because both her mother as well as her maternal aunt had had a history of unprovoked deep vein thromboses, or blood clots that occurred for no clear reason. And in fact, the patient does tell you that she's been told she has factor V Leiden.
And you need to know more, whether she was a heterozygote for it or a homozygote. There's probably a bunch of people in this room who've never had a DVT who are heterozygotes for V Leiden. You and I might be, for all we know. So it's important to flash that out, get an idea about that. It raises a larger question about hypercoagulability broadly, in addition to PNH, which is probably the 25th most common cause of hypercoagulability. There's a lot of other ones, too, and some that run in families, such as factor C deficiency, factor S deficiency, a prothrombin mutation, which is incredibly common. And someone who's V Leiden positive, I would need to know more, because even with heterozygote for V Leiden, I'm nervous about 2 clots in the leg and possibly another one in the spleen. And we had mentioned before, what's more important than anything is to do the right thing, not necessarily get the right diagnosis. So I'd be all over that.
In regard to your question about that, she is actually factor V Leiden heterozygote.
No, heterozygous. So it may be something. Is that anything? Well, who knows?
Well, at this stage, let's go ahead and summarize what we've discovered so far with Dr. Tierney's guidance. We've learned, just as a reminder, that this patient recently had an uncomplicated C-section. She was on the blood thinner enoxaparin previously for the deep vein thromboses, and at the instruction of her docs, she did skip a few doses of that blood thinner prior to delivery. She's been describing this severe left upper quadrant abdominal pain, and she's been having ongoing fever or nausea. Again, unfortunately, she hasn't checked her temperature at home, but she feels as though she has a fever. In way of her past medical history, we heard that she had a prior cholecystectomy, and we also heard that she has 2 deep vein thromboses, which you can see demonstrated in an ultrasound image here, one on the right leg as well as one in the left leg. In terms of her medication, she's on enoxaparin, which is the blood thinner for the DVTs, as well as ibuprofen that she's more recently begun to use to try to control this left upper quadrant pain. And then in way of family history, there were some additional asides that I didn't mention: father with a history of heart attack, brother with a history of type 2 diabetes, and then both a mother and an aunt with a history of deep vein thrombosis.
Wow.
So
It's actually a macrocytosis there, not microcytosis.
So at this stage, you've wonderfully navigated a very limited amount of information and are already thinking of a myriad of possibilities. We'll try to help as you hone in your differential with giving you the physical exam as well as the laboratory data.
And I'd like to point out that the physical exam actually, this would be in keeping with Dr. Verghese teaching so elegantly for so long. It begins when you lay eyes on the patient. We always have history, past history, family, social, et cetera, et cetera. Then we go into the physical exam. But you're forming thoughts. When I see anyone, I'm bringing 44 years of my experience and those of my dad, who got out of med school in 1936 and solo practiced in our home in Connecticut. And I watched him day in and day out and day in. In keeping with mentioning papers that too many people are not likely to read, tops, I don't know. But in the American Journal of Medicine a year ago, August, I published a paper about this experience called Once Upon a Time in American Medicine. Nothing as elegant as what we've heard today, but just bragging a little, you know. We're not totally anti-academic up there in San Francisco. So anyhow, that being said, some sense, what do we think? Sick, not sick? If sick, acutely or chronically, you can't unambiguously make that impression. And I'm looking around the room, I'm always looking for sick people all the time, you know. But most people here seem to be pretty healthy by and large. So I want to emphasize that, but go ahead and give us the rest. Tell us if you can remember, you probably can't, but the time of the day that the exam was performed.
She was evaluated at midday, and this is the exam that was initially performed. She was febrile with a temperature of 38.1 Celsius, her blood pressure 118/58, close to normal for what we might expect. Heart rate is 70. Her respiratory rate, the number of times she's breathing every minute, is 15. And she's saturating 98% on room air. She appears uncomfortable due to this left abdominal pain. And otherwise, her ENT exams, ear, nose, and throat, cardiac exams, and pulmonary exams did not initially reveal anything to the examiner.
AI, huh?
No AI of this variety. Her abdomen did demonstrate appreciable tenderness on palpation in the left upper quadrant. Her legs were slightly swollen and tender to compression. Recall that she had had 2 DVTs. And her skin just demonstrated a clean, dry, and intact C-section incision. Neurologically, no abnormalities were noted. Dr. Tierney, as you hear this physical exam, are there any other features that you might look for on the physical examination as you're trying to narrow your differential diagnosis?
Well, I look at this and I see the word grossly, and I'm sure Abraham would agree with me, that needs to be drummed out of the medical lexicon. It means, oh, I thought about doing a neurological, but I didn't have time. Don't do gross. We don't do that. It means that's exactly right. But the exam is somewhat underwhelming and really pretty. I mean, I might look for evidence of infectious phenomena such as conjunctival petechiae, even the optic fundus, which is ignored in the breech, so to speak, in the modern day. But this sounds like a perfectly normal postpartum exam, except for the left upper quadrant tenderness. Her temperature is probably more than 2 standard deviations from the mean at 38.1. And is the pulse of 70 slow for that? Interesting thing to keep in the back of your mind. In other words, you have a fever, your pulse rate should go up. 70 is not too.
And you inquired about conjunctival petechiae. None were noted on exam.
Okay.
Fundoscopic exam was also unremarkable. At this stage, let's turn to some of the basic laboratories. For our audience, the first graphic on top is our convention for indicating cell blood counts. 6 refers to white blood cell counts. Those are indicators of inflammation and sometimes infection. 6 is within normal. 11.7 is an indicator of our hemoglobin, which reflects red blood cell counts. And that's a touch low, though not terribly low for this patient. And then 220 refers to our platelets. Those are the blood cells that help with clotting, and those are within normal. Mm-hmm. The graphic below indicates sodium levels, potassium levels, kidney function, glucose levels, And in short, there are no major abnormalities in those labs as well. Her liver function tests are also within normal. In case anyone in the group might have been thinking about the possibility of pancreatitis, that's inflammation of the pancreas that can cause sometimes a mid-epigastric or upper abdominal pain, a lipase was checked, which can be elevated in that setting, and it was normal.
Shoulder pain, too, with pancreatitis. Kerr's sign is when you lift the left leg up by the heel, out of 90 degree to the trunk, it reproduces pain in the left shoulder in patients with pathology there, KEHR.
At this stage, where would you go next in her case? What would you do as your next step in management?
Any radiologists around?
So there's a call for imaging.
Yes.
And what would you pursue and why?
Well, it's a great question. I've heard the phrase from, I don't know, was John Corona at UCSF when you guys were there, neurologist? He coined the phrase, one CT is worth a room full of neurologists. And while being a little irreverent when applied to the abdomen, I think you could take your pick. She's probably going to get an ultrasound. I bet you she's going to get a CT too. Because if you do it with contrast, what I'm worried about is venous thrombosis, quite frankly, right here. Because of the fever, she needs blood cultures, which is when you draw blood and send it to the lab to see if germs grow out in it, which means she's bad sick, worse sick, but not good to have a clot in the splenic vein. Fairly easily diagnosed either by ultrasound or CT. CT is better for many other things too, like the pancreas and maybe the kidney even. Kidney function normal could be done with contrast, which gives more information regarding whether or not there's blood clots in the abdomen, but that's where we're going.
Indeed, she does get imaging. She gets a CT of the abdomen and pelvis with contrast. We'll just point out that in the first few minutes, you immediately honed in on your concern about the spleen. And indeed, there is splenic pathology. But rather than splenic vein thrombosis, which is one of the considerations that you had, surprisingly, the CT actually demonstrates splenic infarcts.
Yeah.
Dr. Tierney, what are your thoughts upon hearing that, and does that change how you begin to frame this case?
Sort of. Going back to the thing we just mentioned, the blood cultures, this is the kind of thing you see in patients with endocarditis, and I would bring Dr. Verghese to the bedside and let him be the first one to hear, yes, the AI that this patient has. So I would think more of an arterial side event, part of a septic syndrome. Could she possibly have a hint of an abscess left from the cholecystectomy? But I don't think that that rules out venous pathology myself. Is there not a radiologist? I know there are dermatologists here, but that won't help.
And at this juncture, we know that this is a woman who has factor V Leiden, and she's had deep vein thromboses with splenic infarcts.
Yes.
Do you think that it would be possible to see that pathology concurrently in someone who has factor V Leiden?
Absolutely. But 5 heterozygote is just, I think that would probably be your assumption if blood cultures were negative, and I'd be all for that.
And progressively, as her course unfolds, her blood cultures are indeed negative as well.
Good. Great. Well, so 5 Leiden, there are a number of clotting factors in the human and in other primates and other animals, and of them, or like 13 or more, factor V plays an important part in the last part of the clotting cascade. And when you are deficient, it allows a related part of the clotting system to proceed unopposed, producing clotting, where 5 Leiden, its job is to inhibit clotting when present in balance. And when gone, this kind of thing could happen. And this is the sort of thing is that if nothing else is found, and if you decide to do a full hematologic workup, remembering that people on heparin may have abnormalities muted of some of the hypercoagulable states. If it all ends there, I'd end up calling it 5-Leiden okay, but I'd be thinking this is Stanford, this is a CP, clinical problem-solving X-ray too. I'd be worrying about the weird and wonderful that we've already mentioned so far.
And one thing that you've been alluding to a few times in our talk is there something else that could be going on? Is it just factor V Leiden, or is there perhaps another process that could be at play? And that's why you reached for more esoteric things such as paroxysmal nocturnal hemoglobinuria. You're
going to kill me if you end up getting ANAs and also antiphospholipid syndromes, which certainly are legit in this clinical situation. If you have it, this gets really complicated, and I apologize to the non-docs here, but antiphospholipid antibody syndrome is very interesting and highly written about phenomena. It's commonly seen in patients with lupus, but it is not necessarily confined to them. Both of these type of patient and the 5-Leidens would be expected to have artery and vein involved. So the fact that this is an infarct doesn't sway me from APLA.
That's a very interesting thing that you're pointing out, and actually incredibly helpful for trainees like myself is to hear about how you're framing a case and to hear that last statement where you're beginning to frame the case as both arterial and venous clots.
Yeah.
And you're starting to suggest various disorders that can have specifically both arterial and venous clots. I thought you might go there. And so I have included
PNH, number 2 on the list.
I have included a list, and what a delight that you brought up things like paroxysmal nocturnal hemoglobinuria, as well as things like antiphospholipid syndrome. But this list is meant to highlight the list of items that are on the differential for select arterial and venous clots and where they intersect, because it is a relatively short list of less than 10 items.
Mm-hmm.
And so, as you mentioned, you would pursue an evaluation for a number of these entities, and that's exactly what did happen in this case.
Yeah. Let me click off a pearl for each one of them. HIT, H-I-T-T, for heparin would be expected. She hasn't got thrombocytopenia, so no way if she still, although she did stop the drugs for a few days. Let's say it's not that. APLA, yes. PNH, don't I wish. Hyperhomocystinemia gets a lot of ink, but is, again, usually not a factor unless it, too, is homozygote. I would refer you to a session like this in the New England Journal about a month ago. Those patients incredibly have an optic fundus finding called ectopia lentis, which is displacement of the lenses of the eye. It diagnoses it on the spot when you see it. I saw one as a medical student, never forgotten it. Trousseau, this is super bad hypercoagulability and usually superficial thrombosis. I don't guess, but our coagulation people think, boy, clot equals cancer until proved otherwise, but we don't have that here. Doesn't have thrombocythemia. Vasculitis, well, sure, yeah. Nice. DIC, it doesn't sound like she has that. She's not bleeding anywhere else. And a PFO, great thought. It means a little hole in the heart that could lead to a clot from the leg going through that hole into the lungs, or I should say into the systemic circulation and embolizing to the spleen. Wouldn't that be cool? Probably would justify, cost notwithstanding, an echo if you weren't happy with how everything played out.
If you had to pick one out of the list, do you favor one of these?
I'd pick APLA.
And then if you had to pick a second or third, as you're making your selection of 3.
I like PFO. I really do.
Perfect. And what would your third be?
Should I go through all of them? How can? Oh boy, vasculitis, because this is SLE, right?
All right. Well, let's keep those 3 in mind. And as we heard earlier in the day, you don't necessarily need to narrow yourself to 3, and that can often be an area for pitfall. But for a bit of fun, let's just see what comes of this. The patient has a number of studies to slowly work through that list. And here are the negative studies. The HIT panel, the DIC screen, PNH screen, and homocysteine level are negative. And Dr. Tierney said that he felt like an echo, an ultrasound of the heart would be warranted. And this is the patient's echo. And in fact, it does show a patent foramen ovale, which was in your list of 3 diagnoses that you thought might be at play. And it's a really subtle finding, perhaps best seen by those closest to the front of the room. But in a PFO study, we do an echocardiogram of the heart and we infuse agitated bubbles. They shouldn't cross from one chamber of the heart to the other. And if you're close enough to the front, you can see little pixelations floating around on the chamber that's on the right side. And those pixelations are actually bubbles. There is an abnormal hole between the 2 chambers of the heart, and those bubbles are crossing that hole. And this highlights how a subtle echo finding can transform how you're thinking about this case. Here's a visual.
What do you think, you guys? Doesn't have it, right, yeah.
Right. So here is another depiction of a PFO, and again, just demonstrating the hole in the heart. And so there is a PFO. As was mentioned, there is a percentage of the population that does have a PFO. But at this stage, how do you put the case together?
Well, I mean, it could be in this room, a paradoxical embolus, but I'm still worried about APLA, can you say, and SLE. Got to do that.
And I'll say that sometime after this case unfolded, this was some months later, she did have those studies done as well, and they were unrevealing. And so ultimately, I'll tell you at least what the physicians taking care of this patient favored. And of course, this can always be an area of discussion, but they did ultimately favor a paradoxical venous embolism from the DVTs that traveled across the PFO into the arterial circulation to cause splenic infarct. And so pictorially for our audience, what that would look like would be in step 1, a clot in the leg. And again, this is if you buy the theory of what they think the final diagnosis is in this patient. In a patient who had factor V Leiden as well as pregnancy as risk factors for clot, she formed clots in her legs. They traveled up to item 2 in the image, crossed through the PFO, and then went into the systemic circulation to cause those splenic infarcts. What are your thoughts on that possibility?
No, absolutely. What Eric said is of course true, but sooner or later you're going to see one of these. My experience with them has usually been people who have had known pulmonary hypertension in order to provide enough pressure to keep the clot on the artery or to go through the hole and not out into the lung, But it's perfect.
I don't have any last thoughts, but thank you so much for an amazing guest presentation and from irreverent humor as much. Very much appreciated, Dr. Tierney, Dr. Gupta.
Thank you.
Do you guys want to take one question maybe from the audience, or maybe Dr. Graber, if you want to go ahead and start queuing up though. Tweet your question now. Otherwise, I had a really fun comment of the 1 CT is worth a room full of neurologists, and also noting that our neurological exam was grossly non-focal. Is technology going to purposely drive a de-skilling of medicine, and how much does that matter? Have you noticed that amongst your trainees over the decades?
I honestly think it matters because it's part of the demographic that Abraham is preaching, which is lay hands on patients.
But the CT was worth 100 neurologists, right?
I quoted John Corona, himself a neurologist and later chair of neurology at Cornell on that count, not saying one way or other whether I bought it.
Maybe one last thought is you as an expert diagnostician, as a teacher too, forget about a computer. How do you take that expertise in your mind and transfer that to another human being? How do you reproduce that is something that I think is especially important, and I'm sure you have a lot of thoughts on how would you go about doing that.
Well,
or can you do that?
Sure, just have joy with it. Let the patient know that you are bound and determined to find out what this is, that it be something, every one of the things on that list is thoroughly treatable except for Trousseau's syndrome, and try to calm her down while we're going through through the more likely possibilities here.
Very good. Well, thank you again once more to Dr. Tierney and Dr. Gupta.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.